Presenting on behalf of medicine to the heading of Mindful Mind. Presenting Mrs. S, who's a 60-year-old grocery shop employee from Bangladesh, who presented to us with multiple episodes, 4 episodes of altered sensorium for the past 9 months. The semiology is like this. He was apparently well before 2022 December. In December, he was having some sleep disturbances, so he was taken to a nearby hospital and given some sleep medications, the details of which were not available. Following that, on day one, he was doing okay, and day two, he did not wake up. The relatives thought it's probably the medicine that is causing excessive sleep, and they took him to a nearby hospital only the next day. There were no documented focal neurological deficits, but the research summary says that it was thought to be a probable TIA, started on SAPT and statin. This hospital stay lasted for 4 days, and within 4 days, patient was symptomatically better. And had woken up. He was feeling tired, but was able to do activities of daily living, walking without support, and he was working till June. When in June, he had another episode of similar loss of consciousness, where he was admitted for 5 days, thought to be a multi-infarct state, treated with again single antiplatelet and statin. Told in that hospital by the doctors that he had a seizure during the hospital stay, but the relatives had not witnessed it, and he was started on injection levipils. They've also documented saying there were some extrapyramidal symptoms in the form of rigidity and a few tremors, and was started on syndopa. During that time, he also started having memory disturbances, but even at this point of time, after 5 days, he had woken up. He was still being able to walk without support, but he was not able to go to work. His work is in a grocery shop as an employee to do calculations, to give the grocery things, which he was not able to do. So he stopped working at that point. And then again in August, he was at home. And again in August, he had similar complaints, taken to a nearby hospital, admitted for 4 days. He had improved to a state where he was bedbound, responding to oral comments. And at the home, again, after 15 days, he developed a similar episode of altered sensorium. At this point of time, he had come to CMC. So there was history of slowness of speech over the past 8 months, imbalance while walking on and off for the past 8 months, excessive tiredness and altered sleep pattern for 8 months. There was no tremors, no history of seizures, no history of vomiting, blurring of vision, no history of any fever or trauma. This past history, he was diagnosed with diabetes at the December admission, but then in August, they had stopped medications because his blood sugar levels were within the normal range, even without diabetic medications. Also on hypertensive medications, he was started on single antiplatelets. For the extrapyramidal symptoms, they had started him on syndopa. For the probable Cori seizure episode that doctors had witnessed, he was also on levipil 750 BD. During this past 8 months, 2 imaging was done. Both were MRI brain, which had shown only chronic ischemic changes suggestive of a lacunar infarct and bilateral cerebral white matter. When he came to us, his respiratory rate was 20. He was maintaining saturation of 99% in room air. Blood pressures were 110/70. Pulse rate was around 110 per minute. His GCS was 8/15, E1, V2, and M6, but maintaining airway. And the cardiovascular system, because of the tachycardia, he had a flow murmur and systolic murmur, and the RS examination had shown minimal bilateral infrascapular and infraxillary crepitations. Perabdomen was soft, non-tender. There's no free fluid. Spleen was palpable 2 centimeter, below the left causal margin. On PR examination, there was fresh bleed, external and internal hemorrhoids were present. His CNS examination at the time of presentation, we were not able to assess the higher mental function. Pupils were bilaterally equal and reacting to light. Dorsal was preserved. There was no other cranial nerve deficits. Power could not be assessed, but it was observed that the patient was moving all 4 limbs. There was hypertonia, more on the right side than on the left. There was hypertonia bilaterally. Cogwheel rigidity was also more predominant in the right side upper limb than on the left side upper limb. Reflexes were 2+ bilaterally. Plantars were bilateral flexa. Sensory and cerebellum we could not assess. There was no evidence of any neck stiffness. So this is a 60-year-old gentleman who has had 4 episodes of altered sensorium since December, which recovers spontaneously by day 4 or 5. And patient attaining a new baseline after every event. At presentation had splenomegaly with parectal bleeding, and CNS examination revealing a extrapyramidal syndrome, a cogwheel rigidity. So for the acute onset altered sensorium, the differentials that we considered were a metabolic encephalopathy, hypo or hypernatremia, hypo or hyperglycemia, hypocalcemia or hypomagnesemia, or hepatic encephalopathy, uremic encephalopathy. or it could be a multi-infarct state that was causing a altered sensorium, bara meningoencephalitis. He did not have any fevers, but considering he's an elderly gentleman, we also thought of sepsis with septic encephalopathy. Other differentials were non-convulsive status epilepticus, because he was outside he was started on syndopa in an outside hospital. We also thought of Parkinson related off phenomenon, but it's more likely a motor worsening than a cognitive decline. So it was considered a little lower down. The other lower down differentials were either a paraneoplastic or leptomeningeal carcinomatosis, bara neuroleptic malignant syndrome, considering that he had a rigidity. So for the altered sensorium, we started working up, which we found that in CT brain, there was a tiny calcified granuloma in midline cerebellum. Otherwise, only a chronic lacunar infarct in the right posterior limb of internal capsule. This was not giving anything to suggest why he was altered. So we continued further working up, where we found all his metabolic parameters, sodium, GRBS, calcium, magnesium were all normal. Only that ammonia was slightly elevated. Ammonia levels were 194. And we also did an ultrasound abdomen, which showed features suggestive of chronic liver disease with portal hypertension. For the sepsis, we sent cultures which were all negative. In view of altered sensorium, lumbar puncture was also done. The opening pressure was normal. The lumbar puncture picture was also normal. Cultures were negative. PCR was also negative on the lumbar puncture. However, CPK was also slightly elevated, 146. So in view of non-convulsive status, we did a EEG, which was showing persistent slow waves in theta and delta range over bilateral hemispheres. And LFT had shown hypoalbuminemia with mild hepatitis-like pattern. PT was deranged. PT was 22.8. INR was also slightly elevated, 1.75. So considering all his investigations, we came to a conclusion that it was a CLD with portal hypertension, and whether it was a hepatic, probably a hepatic encephalopathy, because the recovery was spontaneous. There's no documentation saying why he had the altered sensorium. There's no other evidence in the previous reports. So I'll come to how the progress was in the hospital. So we continued the etiology workup for CLD, which was all actually unyielding. So we thought it's probably because of a NASH, because outside hospital had shown that he had high blood sugar levels during their admission. Further, we proceeded with the MRI imaging, which gave us a diagnosis, which showed T1 hyperintensity in bilateral globus pallidi. That is when we found that CLD can cause manganese deposition in bilateral basal ganglia, which is called acquired hepatolenticular degeneration, which has this insidious course where patient develops multiple episodes of altered sensorium and then improves. This can also be interspersed with episodes of hepatic encephalopathy. This was the MRI image. I don't know whether you're able to see it properly. Bilateral global pallidi showing T1 hyperintensities. This was the diagnosis. So on day 3 of admission, patient sensorium improved after we relieved his constipation. And for the PR bleed hemorrhoids, we had started him on local nifedipine gels and lignocaine gels. So after that, he had improvement in sensorium. After that, we found that patient had delirium, altered sleep pattern on and off with cogwheel rigidity, hypomimia, slowing of speech, and bradykinesia. Again, per abdomen, we rechecked, which was showing only splenomegaly. There was no peripheral signs of any CLD. So a final diagnosis was patient in hepatic encephalopathy with acute hepatolenticular degeneration and atypical Parkinsonism, secondary to a CLD, which is probably secondary to a non-alcoholic fatty liver disease, CTP grade C, and MELD score of 14. So I would want to highlight in my presentation about acquired hepatolenticular degeneration. What are the questions I'm going to address? So what exactly is this? Why does this happen? How do we suspect? How do we treat? And what is the long-term prognosis? So what is hepatolenticular degeneration? It's a neurological complex of syndromes in a patient with advanced liver cirrhosis or portosystemic shunting. A patient develops multiple movement disorders or cognitive impairments. Is it common? Yes, it is. In 1 to 2% of all CLDs, we'll expect acquired hepatolenticular degeneration, and it has a male predisposition. And patients presenting with Parkinsonism in the spectrum of acute hepatolenticular degeneration is 10.5 to 25%. This was a spectrum our patient was falling in. Why does this happen? In CLD where there is a portosystemic shunting, there is accumulation of toxic substances in brain like ammonia and manganese, which increase the excitotoxicity in the brain and alteration in the glutamine synthetase, where there is impaired removal of ammonia. These all finally lead to oxidative stress causing neuroinflammation, and patient gradually develops widespread neurodegeneration. When do we suspect? If we know that the patient has CLD and is developing movement disorders, typically a Parkinsonism or an ataxia plus syndrome, or if there is cognitive impairment which is not explained by anything else or psychiatric symptoms, or if there is myelopathy. Even there are case reports saying CLD presenting as acute hepatolenticular degeneration in a myelopathy form where patient has spastic paraparesis. So to just consolidate it to one thing, acute hepatolenticular degeneration, the middle column, it is the etiology is CLD. It is due to toxic substance accumulation. So I was looking up whether, because this patient was diagnosed as CLD in our visit, so is it a new onset CLD that is causing this, or it's the patient long term causing it? Whether there is a temporal association between the two. There are case reports saying that patients can be diagnosed with CLD at the present when they present with this acute hepatolenticular degeneration also. So there's no clear time relation between whether the onset of cirrhosis and the onset of acquired hepatolenticular degeneration, and the clinical features as described. And patients can have normal or slightly elevated ammonia levels. The typical thing is increased manganese levels in whole blood and CSF. Most case reports have found that only T1 hyperintensity in globus pallidus, putamen, and substantia nigra. Other imaging can be F-DOPA and DAT scan, which can also reveal that increased metabolic activity, but sometimes they can also have reduced metabolic activity there. Management is there's no established treatment. We just treat the hepatic encephalopathy, avoid constipation, prevent SBP, and the only management that can actually reverse this process is liver transplantation. It can completely reverse, and there are case reports saying after liver transplantation, the deposition had actually the T1 hyperintensity had actually disappeared. Otherwise, symptomatic management for Parkinsonism with levodopa, but there are no clear benefits per se. So the definitive treatment is liver transplantation, and we do only symptomatic management. In our patients with relieving constipation and treating for the hemorrhoids only, patient had woken up within day 3-4. We'd also educated the family that it is a progressive disorder and only treatment is to prevent patient going into hepatic encephalopathy. We've started on medications for the same. For the rigidity and bradykinesia, we've started him on levodopa. At discharge, he was ambulated with walker support.
Thank you. Any questions? Did we measure a manganese level? This patient also had typical features of there were multi-infarct features on the MRI, even here as well, and 2 MRIs documented outside. How can we be sure that that was not the etiology of the Parkinson's?
Yes. So we had discussed with the neurologic team in radiology and also with the neurology team. They told that the lacunar infarcts at those sites were unlikely to cause like improving and deteriorating type of altered sensorium is unlikely to be seen in those kind. Patients usually have a static or a very minimal improvement, not like this.
No. That could be, of course, attributed to the hepatic encephalopathy. But his Parkinson's
could be vascular.
How can we be sure that it's because of a hepatolenticular degeneration? But is there anything to differentiate the Parkinson's in this two?
Not
that it makes a difference to the management, but
so only imaging extra that can be done is a spectroscopy to measure the brain levels. It shows that the glutamate to so some ratio reversal will be there if we focus on the globus. I'll read up.
Thank you. We have one more. Shannon from Medicine 4.